Hello, everybody. I think we were just letting everyone kind of gather and waiting for those last minute participants. I know me, if I hadn't set an alarm 10 minutes early, I was going to be late today. So we are going to get started. Welcome to VHL Day. Thank you, everyone, for coming. I'd like to start out our session with a gentle reminder and a call to continuous action, just with a land acknowledgement. The majority of Canadians and us here today continue to benefit from the land that was stolen from the Indigenous people, like the Mi'kmaq in my local area in Atlantic Canada. My gentle reminder is not meant to hammer another nail of guilt or shame, but to remind us to continue to recognize their legacy with gratitude and to ask you to open your hearts to help build an equitable future for all. By acknowledging the mistakes of the past, we can then begin the difficult work of changing our present and future for all Canadians. My call to action is for you to continue to hold institutions and people accountable for their responsibilities, such as finding and preventing missing and murdered Indigenous women, and providing affordable housing, which disproportionately affects the most vulnerable in our communities. So with that, again, welcome. I am so happy to see all of us gathered here today. It is the end of VHL Awareness Month, and what better way to finish it off with our first ever VHL Day. Today, we're hoping to learn more about Von Hippel-Lindau and to begin to create a pan-Canadian VHL community. My name is Jess Pearson, and I am the chair of the Canadian VHL Alliance, or as we like to call it, the CVHLA. So you might hear that a lot today, CVHLA, as well as the acronym VHL for Von Hippel-Lindau. The CVHLA, we are a small volunteer nonprofit that has been active for over 20 years. Our vision is to improve the quality of life for Canadians who live with VHL and their families. In the past, we focused on fundraising and are proud to say that we have funded close to $500,000 in Canadian VHL research. In the last year, we have created and recruited a scientific medical advisory board to help guide us in the medical community. The medical community. We have developed a new brand and logo, and we are about to launch an updated website. We have a lot of big dreams for the future, and we're always looking for board members or volunteers to help with our projects. Please don't hesitate to send us an email or reach out on our socials if you're interested in joining us. We also send out a newsletter occasionally if you're signed up for our email list. The realization today of VHL Day is a massive accomplishment for the CVHLA, and I really want to take a moment to thank all of our speakers, the organizers, and you, our participants. VHL Day this year came about because of our Medical Advisory Council, whose goal is to increase access to treatment, improve VHL care, and advocate for VHL warriors across Canada. I am so pleased to have members of the council, Dr. Miriam Soleimani, Renee Hofstetter, and Alexander Volinick presenting here for us today. Just a few housekeeping questions. Just so everyone is aware, I think there's been a pop-up. This is all being recorded, and we plan to display it on our website later. I'd also like to say that everyone is muted and your videos are turned off. If you wish to ask a question live, feel free to raise your hand. So for those of you who have never used Zoom before, either at the top of your screen, sometimes if you're on a cell phone, or if it's at the bottom of your screen, there should be a way to kind of like raise your hand. There is a chat box. We are hoping to reserve the chat box for asking questions to our moderators and our tech support. So that's like if you're having trouble unmuting or you can't hear properly, please write that in the chat. There will be an opportunity for questions at the end of every session, and feel free to write the questions as you think of them during the session, and you can find those in a Q&A portion. So right now, at the bottom of my screen, there's kind of 3 dots and it says More. And under the menu there, it says Q&A. So if you open that, there's a box where you can type in your questions. So if you can, try to put all your questions for the panelists in the Q&A portion. I think that's all I have for housekeeping. Without further ado, let me introduce you to Dr. Miriam Soleimani, and let's get VHL Day started. So Dr. Miriam Soleimani is a genitourinary medical oncologist at BC Cancer, which is located in Vancouver Cancer Centre. She is a clinical assistant professor at the University of British Columbia. She completed her Bachelor of Science and physician's degree, followed by internal medicine residency at the University of Alberta. She then completed medical oncology residency at UBC, followed by a clinical and research fellowship with a special interest in immuno-oncology, renal cell carcinoma, and cancer care delivery. She has received multiple recognitions for academic work. She is actively involved in both clinical and translational research and in oncology clinical trials, with a successful track record of publications in peer-reviewed journals. In 2022, after identifying an unmet need, she founded the BC Cancer von Hippel-Lindau Clinic, which is the first comprehensive clinic in Canada for patients with VHL. She is also leading the development of the Canadian VHL Clinical and Research Consortium and is a chair of the Scientific and Medical Advisory Council of the Canadian VHL Alliance. Welcome, Miriam.
Thank you so much, Jess. It's really great to be here, and I'm really excited about the agenda today. I really want to encourage lots of questions as we're going through it, so please do type those. I also want to just take a moment for land acknowledgement. I am very gratefully present today and have the privilege to present from the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations here in beautiful British Columbia. These are my disclosures, and none are relevant to today's discussion. So this is the agenda for this first talk today. I want to really walk you through Belzutifan, and the audience here today. We have patients, advocates, and healthcare providers. So I hope that I can present this information in a way that makes sense for everybody. I think to appreciate how we've gotten to where we are now with Belzutifan, which is a true paradigm shift in VHL disease, we have to look back at the history of VHL, how historically we've managed it, and some of the trials that have led us to this point. And then we'll talk about the drug itself, the evidence for it, who benefits from it, who needs it, what are the side effects, and then I'll finish off with some take-home points. So the history of VHL is, to me, always very fascinating, and it's really not that long ago that we came to recognize first the term VHL was coined in 1936, and then in 1993, which is really not that long ago, though it may be before some people here were even born, the VHL gene was identified. And then we started to learn about abnormalities of the VHL gene and what that gene is responsible for. By 2001, we found the link between the product of the gene, which is the VHL protein, and something called HIF-alpha, and we'll talk about this in a moment. And then, of course, in 2021, Belzutifan, which is a drug that targets this pathway, was developed. So this is really a success story. So as a bit of a review, without getting too bogged down in scientific details, if you have normal functioning VHL protein, as the majority of the population does, there's a process by which these residues called hypoxia-inducible factor A, HIF-alpha, they go through a long pathway that ultimately leads to their degradation. And that's important. In a patient that has VHL disease, where their VHL protein is not functioning appropriately, you can't degrade those HIF-A residues. And so they accumulate and they link up with something called HIF-B, and they form a complex that leads to changes in transcription of DNA, and that ultimately leads to the development of the tumors that we see in VHL. And this VHL pathway that I just described is not only relevant in VHL disease, but I see in my practice patients with clear cell kidney cancer who don't have a history of VHL disease. And this pathway is abnormal in about 90% of the tumors of those patients as well, though they don't have it sort of from a genetic aspect, and they don't get the other manifestations of VHL. And our understanding of this pathway was so important in medicine. It was so revolutionary to so much of our understanding about things like fetal development and our immune system that in 2019, the group that sort of developed and published on this won the 2019 Nobel Prize in Physiology and Medicine. So here we have VHL disease, a small, rare disease that has made a huge impact in medicine in a way that was truly recognized with the highest honor in medicine. So as a result of this abnormality, lesions develop in different areas of the body, and many of you live through this and are very familiar with going through the surveillance that's done to monitor the eyes, MRI scans or CT scans of the brain and the spinal cord and the abdomen, the dreaded urine collections that I know are a pain. And really what we're doing is we're trying to keep an eye on where lesions develop so that we can do surgery and cut them out. That's how we've historically dealt with it. And depending on which area of the body we're talking about, sometimes when a lesion grows to a certain size, we cut it out. For example, kidney tumors, they get to about 3 centimeters, we want to cut them out. In other areas of the body, it depends on whether they're causing symptoms or not, and not so much on the size. Now, the challenge with the approach for surgery is that surgery is not altering that underlying issue that we discussed in that pathway. So you will continue to develop areas of disease again and again and again. And our surgical techniques and our surgeons are incredible these days. And they're able to do excellent surgeries to preserve as much healthy organ as possible. But you can only do so much. And as many of you know, you will continue to develop lesions recurrently. So for example, you can only cut out so much kidney tissue before you no longer have healthy kidney tissue left and patients need to go on to dialysis or renal transplant. The retinal disease in VHL not only can cause loss of vision itself, but even the procedures that are done can sometimes affect vision. Neurosurgery, of course, comes with complications as well. And so ideally, a treatment for a VHL would be one that reduces the size and the number of tumors, defers the need for these surgical treatments, and maintains organ function so patients can live better and have better health outcomes and have better quality of life. Going through repetitive surgeries and the worry of always needing surgery is tremendously stressful. So if we can avoid the need for surgery and take a proactive approach, it really would make things most ideal. So what do patients want? In the midst of all of this, it's important to sort of understand the patient perspective. And there was an interesting study that was presented at ASCO. ASCO is a very big international oncology meeting that's held annually in Chicago. And this was presented last year. This was a survey of 220 patients with VHL, and a portion of those patients were from Canada. And they asked these patients some questions about different scenarios of the sort of treatment they would want. It's important when we look at clinical trial data to make sure that the population of patients within the study is representative of our population where we live. 89% of patients in this study were Caucasian. So in a diverse country like Canada, perhaps that's a bit skewed. 68% were female sex, and you can see sort of the age distribution. And many of these patients were working full-time and had sort of the typical manifestations of VHL with kidney cancer tumors and central nervous system disease. So they asked patients which areas of your body have been operated on in each of the surgeries that you've had. And most commonly, the areas we run into issues in VHL are the brain and the kidneys, brain and spinal cord, I should say, in the kidneys. So this is, quite an accurate representation of what most patients experience. And then they ask patients, what are your top goals for treatment of your VHL? And you can see here they were to reduce the number of surgeries, be able to go about life as usual, delay the need for surgery, improve quality of life, and be able to plan for the future. So then they asked patients, they give them a scenario. And they said, imagine that you have never had a VHL related surgery, and now you have a VHL related cancer, but you're not quite yet eligible to have surgery. And there's two options. You can either watch and wait, monitor it with regular scans and doctor's appointments, and at some point, this cancer is going to grow large enough that you need to have surgery. Or you can take a pill. You need regular doctor's appointments and scans. At some point, the tumor may grow and you may need to have surgery. You have to take a pill daily, and the pill can have some side effects, but it could slow the growth of your tumor and possibly delay the time until you need surgery. So they asked patients, which approach would you prefer? And you can see here, 73% of patients said they would prefer to take a pill. And then they asked them, why? Why do you choose that? Or why did you choose watch and wait? And you can see here that the majority of patients said, I worry about the tumor growing bigger, and so I want to take a pill. Wanting to delay time for surgery, concern about risks of complications or side effects from surgery, and risk that I may develop other VHL-related tumors and chances of survival. So this is important information for us as clinicians because we always want to make shared decisions, right? We're a team. So when you see your clinician, you want to make a decision together based on what your priorities are, based on what the medical evidence is, and sort of what is the sort of safest approach to take. And we have known for a long time that we need systemic therapy, medical treatment for VHL. And I'm not going to go through all of this in detail, but suffice to say that there have been about 3 or 4 trials that looked at different drugs. These are all oral targeted therapies that we use in the management of kidney cancer for patients who don't have VHL. And essentially the challenge that came from all of these studies, they were small studies. This one had 31 patients. This study with sunitinib had only 15 patients. Dovitinib had 6 patients. The challenge that the results showed us was that unfortunately the response rates were not very good, and the treatments were quite toxic, and a lot of patients needed to stop treatment. So none of these drugs ever got approved for use in VHL by Health Canada. And then Belzutifan came along, and Belzutifan is the first medical treatment for VHL disease. So to understand how Belzutifan works, we have to go back to that first slide that I showed you. Remember, I mentioned that because VHL protein is not working normally in a patient with VHL, the HIF-A's accumulate, they pair up with HIF-B, and then that is ultimately what leads to the development of the VHL-associated lesions. When you take Belzutifan, it prevents HIF-A and HIF-B from pairing up, and so you don't get the activation of those genes that leads to the development of tumors. So we call Belzutifan a second-generation oral inhibitor of HIF-2 alpha. It is an oral medication, and I know some of you who are joining us today are quite familiar with it. It's taken at a dose of 120 milligrams a day. That's 3 40 milligram tablets a day, and it has some unique side effects that we'll talk about momentarily. So the clinical trial that ultimately led us to this point was called the LIGHTSPARK-004 study. So this is a study schematic, a study design that tells us in a graphic form sort of how the study was designed. So patients in this trial had to have a confirmed diagnosis of VHL. They had to have had the genetic testing, and they had to have at least 1 kidney cancer tumor on scans. And they could not have metastatic kidney cancer or metastatic other types of cancer. There were 61 patients, so that's the largest patient study that we've had to date. And everyone received Belzutifan at the standard 120 milligram oral daily dose. Endpoints in a clinical trial are sort of what are the ultimate goals that we're trying to address? What are we looking to determine from this study? And the main endpoint of this study was something called ORR, which is objective response rate. So seeing a reduction in the size of tumor based on scans. And initially, the company that was running the trial wanted to only look at the response in kidney cancer tumors. And the clinicians who were involved in the design of the study told them, we really think we should look at all the areas of disease in VHL. So the secondary endpoint was the response rate in other VHL-associated neoplasms or tumors. So let's have a look at the results. As clinicians, when we look at clinical trials, the first thing is always the table one, as we call it. And the table one kind of lays out for you who were the patients in this trial. Because when I look at the data, I want to know, were the patients in this trial the same or similar in their characteristics to the patients that I see in my VHL clinic, so that I can actually apply the findings appropriately to my patients? Are my patients going to derive the same potential benefit? And the average age of patients in this trial was 41 years. Most patients had type 1 VHL. This is what we most commonly see. You can see 66% of patients had 4 or more prior surgeries. So this is very much a true representation, an accurate representation of a VHL population generally. So this is the response rate in kidney cancer tumors, a response rate of 64%. This means that 64% of tumors that were evaluated shrank by a specific percentage in their size on scans, which is really impressive. This is excellent data. We break down the type of response in oncology depending on the degree of change that we see. CR means complete response. So this means the kidney cancer tumor actually disappeared on the scans. So 7% of patients actually had their kidney cancer tumor completely disappear. PD means progressive disease, means the number of patients whose cancer kept growing, and 0 patients had their tumors continue to grow. So this is really exciting. In terms of the duration of treatment, so on this plot, each line is a patient that was on the study. And as you see here, it says the median time to response was 11.1 months. This means that despite the fact that when you start Belzutifan, we do scans usually every 3 months for the first year that you're on treatment, we may not necessarily see a response until, closer to a year of being on treatment. In my experience, we do actually start to see a response around 4 months or so, and then it will continue beyond that. And what about in other areas of the disease? So in the central nervous system, so brain and spinal cord lesions, 44% of tumors shrank, which is excellent. And depending on sort of whether you're looking at the cystic component of a spot in the brain versus the solid component, those numbers vary, and I'm not going to get into that too much today for time reasons. In terms of pancreatic neuroendocrine tumors, Dr. Johnson is going to speak a bit about neuroendocrine manifestations later. In pancreas lesions, 91% response rate, 91% of tumors shrank. And in eye disease, it was a small number, 16 eyes that were evaluated, but 100% response rate. This is really impressive and exciting. So it's great that we have this data. It's clearly impressive. Well, does Belzutifan work for pheochromocytomas? We'll hear a bit more about pheochromocytomas later. And the answer to that is there is no evidence to date. So there is a clinical trial similar to what I just presented that looks specifically at pheochromocytoma. We don't have the results reported yet, so we're waiting for that. So for patients who have pheochromocytomas, the standard treatment of surgical management remains at this time, and we'll wait and see. Pheochromocytomas develop in a slightly different way than other VHL lesions, so we just don't know whether Belzutifan works or not. So it's great that it's an effective treatment, but is it well tolerated? And this is a table graph that shows the most common side effects that patients experienced. In clinical trials, we grade side effects. So grade 1 and 2 side effects are side effects that are a nuisance. They're present, but they're not impairing your day-to-day function. You can get on with life, but you notice them. And grade 3 and higher toxicities are the very severe toxicities. And as you see here, most patients, pretty well everyone, experiences some side effects, but those tend to be low-grade side effects. So we're going to talk a bit about some of these side effects in a moment here. Anemia is very common. Fatigue is quite common. And those of you who are on today who have experience with taking this drug can attest to that. Headaches, dizziness can happen. And then there are more rare side effects as well. We're also going to talk about hypoxia, which is lowered oxygen levels in the blood. In the clinical trial, they reported one patient in the whole study that had hypoxia, and then when reducing the dose of their belzutifan, that resolved. In my experience, it happens a bit more often than that, but is always quite manageable. I think this is probably one of the most important pieces of data that came out from the trial. So here you see again, each line is a patient, and each dot or spot is a different type of surgery. And you can see the legend here in terms of type of surgery. So time 0 is when a patient started belzutifan. So you see in the 4 years prior to belzutifan, each of the types of surgeries that patients had. And then they started belzutifan. And you can see clearly far fewer surgeries are being performed. And this is a good thing. This means that patients can get on with life. We're able to manage their VHL disease. They don't have to worry about those surgeries and the complications that may come from it. You'll see, though, that despite being on belzutifan, some patients still required surgeries. And that's very true. For reasons we don't completely understand, in any one patient, certain areas of the disease may respond to belzutifan and others may not. And in a family with the same genetic mutation, some may respond very well to belzutifan and others may not. So belzutifan doesn't completely omit the need for surgery. It can help us defer surgery. But even if you need a surgery, it doesn't mean you have to stop belzutifan, because let's say, for example, it wasn't working so well to control your kidney tumor, but it's doing a great job controlling the spots in your brain. So your healthcare provider may say to you, you know what, we need to do surgery for your kidney spot, but then you can stay on belzutifan after because it's working well otherwise. So I want to just talk briefly about some of the side effects that are a bit unique with belzutifan. The first one I'm going to talk about is anemia. So anemia is a reduction in hemoglobin. Those are the oxygen carrying cells in our blood. And as you see here, time 0 is when a patient started belzutifan on this study. Males and females are on different lines. Females tend to have more iron deficiency anemia. They have menstruation. They're more likely to be anemic to start with. But you see the hemoglobin level drops around the first 3 months or so, and then it stabilizes out. You see the line generally flattens out. And this is very much what we tend to see in our day-to-day practice as well. We can manage the anemia by changing the dose of the belzutifan. Very rarely does it have to be completely stopped. We want to make sure that you take iron if you have iron deficiency anemia, so you should get your iron levels checked before you start treatment. Very rarely, I've never had to do it. You can also do transfusions if the hemoglobin levels go severely low. Hypoxia refers to lowered oxygen levels in the blood. So belzutifan has some unique sort of mechanisms by which it can lower oxygen levels in the blood. So I always advise my patients, when you're starting belzutifan, you need to have an oxygen saturation probe at home. You can see in the picture here, you can get these at a drugstore or off Amazon for about 20, 30 bucks. And you want to be checking your oxygen levels daily for the first couple of weeks that you start belzutifan. And I ask my patients to keep a diary where they log the numbers. And then over time, your healthcare provider will tell you to decrease the frequency of how often you check it if you don't have issues with hypoxia. The vast majority of patients do not have issues with hypoxia. When you get infections, if you have a pneumonia or COVID or something like that, you want to be monitoring your oxygen levels a little bit more closely to make sure they don't drop. If you check your oxygen levels and your levels drop to less than 90%, the first thing I advise my patients to do is to get up and walk around. It stimulates the breathing centers of your brain, and you take deep breaths, and very often it will resolve. But if it stays at less than 90, you want to stop the Belzutifan immediately and call your healthcare provider. If you feel short of breath or if you have chest discomfort, you absolutely go to the emergency department right away and you let them know that you're on this medication. And in specific scenarios, the Belzutifan dose may have to be reduced to address this. And if it's very severe, your healthcare provider may tell you that actually needs to be stopped. Again, quite rare that that happens. Vision changes are tricky because, as many of you know, patients with VHL develop vision changes as a result of their retinal disease. And there's sort of different side effects in terms of vision toxicity that Belzutifan can cause. Some are nuisance side effects, dry eyes, some swelling around the eyes. They're not dangerous, but they are annoying. But there are also some very serious side effects that can lead to permanent blindness. So if you ever experience vision changes, if you see floaters, if you suddenly get a dark vision like a drape comes down, seeing flashing lights, these are scenarios where you stop your Belzutifan immediately and you call your healthcare provider right away, or you go to the emergency department if it's after hours, because they need to make sure to rule out things like retinal detachment or blockage of your retinal vein, which can cause permanent vision loss. Fertility is something we're still learning about in the context of Belzutifan. We don't have a lot of data around how Belzutifan can affect patients' fertility, and this is both for biological males and females. The data to date suggests that it probably doesn't, but because we don't have a lot of data, we want to make sure we're very cautious about it. Belzutifan is very teratogenic. That means it's very harmful to the fetus. So when you are taking Belzutifan, you need to make sure that you are using some form of contraceptive to prevent pregnancy. Oral contraceptive pills can sometimes interact with Belzutifan in a way that makes the pill less effective. So preferably things like IUDs or condoms are best to use. But none of this is to say that if you start Belzutifan, you can never have children again. I send all of my patients to a fertility clinic to have a bit of a discussion about fertility preservation options. I have had patients who have succeeded in becoming pregnant after being on Belzutifan, and most of my patients who menstruate have regular menstrual cycles with Belzutifan. It's also important to remember that Belzutifan may be passed along through breast milk to babies, so you cannot breastfeed while you're taking Belzutifan. None of this is to say that, you can never have pregnancy and you can never breastfeed. It's about trying to plan these things as much as possible, if we can, so that we can, stop Belzutifan. Then patients will attempt to conceive after a period of time being off drug. I usually tell my patients a month of being off of it, and then go through pregnancy, delivery, breastfeeding if a patient chooses to do so. And then when all of that is done, then they can resume their Belzutifan. So it's just about sort of, communicating and collaborating with your healthcare team. But please, if you ever are late on your menstrual cycle, or if you suspect you're pregnant, please immediately stop your Belzutifan and contact your healthcare provider to get a pregnancy test. For the healthcare providers in the audience, there are tool cards for management of side effects with a bit more sort of detail, so please reach out to me. And in terms of patient information on the BC Cancer website, if you just Google BC Cancer Belzutifan, it's the second or third hit that comes up. We do have a patient handout that goes through some of what I've discussed here, and the new CVHLA website will also link to this, so you'll be able to access resources. So take-home points: Belzutifan has truly changed the management of VHL disease. However, not everyone with VHL needs Belzutifan. Just because you have spots in the brain or just because you have a kidney cancer spot does not necessarily mean you need Belzutifan. In some cases, surgery is absolutely most appropriate. And so the decision as to whether you need Belzutifan or not is one that you need to have with your healthcare provider and to kind of discuss as a team. We don't yet know whether belzutifan also prevents the development of new spots or if it just shrinks down existing spots. I can tell you from our experience here in BC, it certainly seems to prevent the development of new spots, but we need larger studies across Canada and across North America to be able to say that, more confidently. Not everyone benefits in the same way from belzutifan. So some people have a wonderful response. Others may need surgery after some time. And so it's important to kind of understand that surgery is always something that is in the back of our minds and in our pockets. Belzutifan is a very well-tolerated treatment, but it has some unique side effects. Each person is different. Some people have absolutely new side effects. Some people get the very rare side effects. So in our VHL clinic, when a patient starts belzutifan, they have a nursing call out every 2 weeks for the first 2 months that they're on treatment, just so we can keep a very close eye on things. And belzutifan is the first drug in this class that targets that HIF alpha that I mentioned, but it's not the only one. There are more coming. So stay tuned. You're going to hear more and more about this. And I think it's a really exciting time for systemic therapy in VHL. So in terms of how to access belzutifan, it was approved in 2022 by Health Canada. In 2023, they expanded the indication. So it's for patients who have non-metastatic kidney cancer tumors, non-metastatic CNS, so brain and spinal cord hemangioblastomas, and non-metastatic pancreatic neuroendocrine tumors. In August, it got a positive recommendation from an organization called CADIF. CADIF reviews data around drugs and gives a recommendation on whether they think the public healthcare system should reimburse it. And they recommended that it should be reimbursed, but conditional on a price reduction with the manufacturer. And it remains in price negotiations right now. Until the beginning of September, there is a compassionate access program. So the company provides the drug free of charge until September. That's been open for a couple of years now. And as we'll talk about in a moment, we're really trying to set up a network of clinics across the country to allow patients to know where to go to access it. So I thank you very much for your time. Very happy to take any questions you may have.
Wow, that was really informative, Miriam. Thank you so much. We have one question so far from Nancy Rose. If a patient on belzutifan needs surgery, do they need to stop taking it before or after the procedure for some amount of time?
That's an excellent question. Thank you for bringing that up. Yes, they do. Because of the pathway that belzutifan affects, it can impair wound healing and increase the risk for infection. And so what we tell patients to do is to stop treatment for about, depending on the extent of the surgery, for major surgery, 5 to 7 days before surgery, and then to not start it again until wounds have healed up, staples or sutures or whatever are removed and everything's nice and healed. Minor surgeries, like you need to get, a small tooth surgery or a little mole removed, for example, you only need to stop it, 2-3 days prior, and you can usually resume it pretty quickly after. But thank you very much for bringing that up.
We have another question. Can cataracts be related to belzutifan?
I think what they're getting at is, can belzutifan cause cataracts? I think to date, we don't specifically have data that tells us that. Sometimes that's one of those things that, with longer term data, after 10, 15 years, we get some information about that. But as far as we know, it doesn't necessarily cause cataracts.
I actually had a question. You mentioned one study that's ongoing about, I think, the PHEO, studying belzutifan in PHEOs. Do you know of any other ongoing studies?
So right now, that study with pheochromocytomas is actually closed. So it's not taking on new patients, and they're analyzing the data. So we don't have the data yet. There aren't other studies specifically for VHL. Belzutifan is a drug that is also being studied in kidney cancer, sporadic kidney cancer, so clear cell kidney cancers. As I mentioned, most of them have abnormalities of the HIF pathway that we discussed. So we have seen data that shows that belzutifan works quite effectively in kidney cancer that's been treated with many other types of drugs like immunotherapy and targeted therapies. There are other trials that are looking at belzutifan to be given after removal of a kidney tumor or in the first line setting when a patient develops metastatic kidney cancer combined with immunotherapy. There are trials that are looking at combining belzutifan with other targeted therapies in other tumor types as well. So it's a drug that really is actively being studied in many areas. But in terms of VHL patients, there aren't other studies at present. That does remind me also, I didn't mention whether there's data for use in pediatrics. Some of you may be wondering that. There was a clinical trial that enrolled children, so those less than 17 years of age with VHL to receive belzutifan. That study is now closed. It's not yet reported, so we don't have the data for that. And part of that is because we really need very long-term safety data in children because their bodies are growing and developing, and we want to make sure that we are not causing any sort of, impairment to naturally occurring processes of puberty and things like that.
We might just take one last question. And then if anybody else has other questions, we can maybe answer them at the break or later on. Miriam will be speaking again. Oh, I'm sorry. We have two questions. I am 71 and I've been on it for 2 years and have dropped to 80 milligrams. I'm on home oxygen for hypoxia. Am I the only one in Canada on home oxygen?
Well, I don't know if I can say whether you're the only one because I look after a very large population of patients with VHL here, but of course I don't know everyone's scenario. I will say in my practice, I have had patients who are on reduced dose of belzutifan for lowered oxygen levels. I have had patients who, when they developed a pneumonia, they did need to be on some supplemental oxygen for a brief period of time. But that was sort of independent of the belzutifan. They needed the oxygen because of the pneumonia. So the answer to that is I'm not sure if you're the only one. I wonder if there probably are other patients as well, but can't say for certain.
And last question for now, have you noticed whether different dosages over time of belzutifan provide different outcomes?
That's a great question. It's very interesting that there are some patients who are extremely sensitive to the drug and they can experience quite significant side effects. And we reduce the dose of the drug and they still see great benefit from it. And we see this also in some of the targeted therapies that we use in kidney cancer, where in patients who are more sensitive to the drug often also derive a bit better benefit. So you can be on a lower dose and still have good benefit from the drug. It's really individual and very, very nuanced. So I think the most important thing is to be keeping very clear logs of your side effects. So keeping a diary of what dose did I take today and what side effects was I experiencing. And in my practice, my patients who've been on belzutifan for a long time and feel quite confident with them, I actually empower them to modify their dose themselves as they sort of assess their symptoms, but keep a log. So when I check in with them, they can let me know, hey, on this day, I was feeling kind of tired. I reduced my dose down, or I took a break for 3 or 4 days. And we can sort of figure out a treatment schedule that works well for them. But a lower dose doesn't necessarily mean lower benefit. It's very nuanced for each person.
Wow, very interesting. There's one last question, but I might get you to answer it maybe typing in the Q&A, Miriam, because we're going to respect Dr. Johnson's time here. Thank you again, Miriam.